Welcome to the monthly podcast presented by JAMA Health Forum. I'm Dr. John Ayanian, the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the editor of JAMA Health Forum.
And I'm Dr. Melinda Buntin, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins University and the deputy editor of JAMA Health Forum. JAMA Health Forum is a peer-reviewed, open-access online journal focused on health policy, healthcare systems, and population health, and one of 12 specialty journals in the JAMA network. Our podcast each month presents highlights of new content from the journal, including timely interviews with authors of research studies and commentaries. Follow us on jamahealthforum.com, on Apple Podcasts, or wherever you get your multimedia, and on jamanetworkaudio.com.
Our guest author is Dr. Benjamin Sommers. Dr. Sommers is the Huntley Quelch Professor of Healthcare Economics at the Harvard T.H. Chan School of Public Health and Professor of Medicine at Harvard Medical School. His research focuses on health policy for marginalized populations, health insurance and the affordability of care, and the healthcare safety net. He is the corresponding author of a new study in JAMA Health Forum titled Survey Reported Coverage in 2019 to 2022 and Implications for Unwinding Medicaid Continuous Eligibility, conducted with lead author Adriana McIntyre and co-author Rebecca Smith, both at Harvard. And he's also an invited contributor to the JAMA Forum section of the journal. Welcome, Ben.
Thanks so much for having me. It's great to be here to talk about this new paper and this important policy issue.
Great. So, Ben, for our listeners who may not be familiar with Medicaid continuous eligibility, what was this policy during the COVID-19 pandemic, and why do we call it unwinding?
Well, if you think back to early 2020, the COVID pandemic had hit and the economy was in a free fall. The lockdowns going on, people being furloughed, large concerns about a recession. And as part of multiple policies that Congress enacted to try to respond to that threat, in March 2020, Congress gave extra money to the states for their Medicaid programs, knowing that enrollment was likely to go up with more job losses and loss of income. And in exchange for that money, the requirement was that states could not remove anyone from their program throughout the course of the public health emergency, even if they became ineligible, with the exception of if people moved or actively wanted to leave Medicaid. This protection stayed in place all the way through April of 2023. And at that point, then states were allowed to begin conducting their eligibility redeterminations again, disenrolling people who were no longer eligible. And this has been referred to as unwinding the continuous coverage provision. So we're now almost a year into this unwinding effort. And based on data as of February of this year, more than 16 million people had been removed from the program. And our research really tried to step in to understand what was going on in the coverage landscape leading up to this.
Thanks, Ben. So what specific research question did you and your colleagues seek to address, and what databases and outcomes did you focus on for this study?
We wanted to understand how coverage patterns had changed during the pandemic. One policy in particular we were interested in was the Medicaid continuous coverage provision, but there was actually also a lot of other activity going on during this period that was potentially affecting health insurance rates. So for instance, there were expanded subsidies for marketplace private insurance that had been enacted under the American Rescue Plan. The Biden administration had really emphasized doing more coverage outreach and had lengthened the period for people to enroll, as well as offering some special enrollment periods. And a couple additional states had moved further into their implementation of their Medicaid expansions that had started a little bit later than some of the other states. So we were trying to understand, broadly speaking, what was happening to all the different types of health insurance coverage during this period of significant policy change as well as economic upheaval. And more specifically focused on the continuous coverage provision, we wanted to understand how the numbers of folks who were being described by states and by the official federal Medicaid statistics as being in the program, which was growing rapidly during the pandemic, how that was mapping onto what people actually understood and experienced of their coverage. And there had been some preliminary research showing that there was this divergence between the number of people that the states and the federal government were described as officially enrolled in Medicaid versus how many of them understood that and were describing themselves as in Medicaid in surveys. So we used the most recent released data from the federal government, the Census Bureau's American Community Survey, which is really one of the gold standard data sources for understanding health insurance as well as the uninsured rate in the U.S. And the most recently available data was through the end of 2022. And we paired that with the official enrollment statistics that states had provided to the Centers for Medicare and Medicaid Services, CMS, which were the way that we knew that the overall enrollment in Medicaid during the pandemic was rising so rapidly as this continuous coverage policy took effect.
So, what were the main findings of your study, and did any of them surprise you?
So the first thing we looked at was just descriptively what was happening during the pandemic in those overall coverage rates. And the outcomes we were focused on here were the share without any health insurance, so people who are uninsured, the share of folks with Medicaid, and then the number of people with private insurance, which is a combination primarily of employer coverage as well as the marketplace plans. What we found was that even though this was a time of such upheaval in the economy, we actually see a decrease in the uninsured rate of a little over 1% of the population, several million more people covered by 2022 than in 2019, the last year before the pandemic. And we also see that the number of people reporting Medicaid went up. But when we compared the absolute numbers of people in the survey saying they'd gained Medicaid to the share that are showing up in the official enrollment statistics from the states and from the federal government, there was a big disconnect. The growth in Medicaid, according to the administrative figures, had gone up by more than 5 percentage points as a share of the total population. But meanwhile, when we looked at the survey, those numbers were only about 1 percentage point or a little bit over that. And so that tells us that despite this historic growth in Medicaid under the continuous coverage provision, most of that wasn't registering as new coverage to the people themselves. Only about a 20 or 25% increase in overall coverage rates or reduction in the uninsured rate compared to this big growth in the number of people listed as covered by the official Medicaid statistics that the government is keeping. And so this implies that a lot of people who maintained their Medicaid during the pandemic didn't understand the details of this continuous coverage provision and maybe didn't even know that that coverage had continued through the whole 3 years of the public health emergency. Some of them had in the meantime gone on to get jobs and a change in income, or maybe had just stopped using Medicaid. And so they thought that coverage had expired. And that seems to be what's driving this pattern. Now, it's not a complete surprise. We know from research even before the pandemic that there was always a bit of a disconnect. It was called an undercount in the surveys around Medicaid enrollment. But what's notable and what was striking to us was how much this disconnect widened, and especially in 2022, which is the more recent year of data we have in the survey. As the pandemic went on, even as those total numbers that were coming out of the official administrative statistics were climbing by 10, 20 million, the number of people who tell the Census Bureau that they have Medicaid was just inching up. We explore the patterns. There are different age groups where we see more of a disconnect. For instance, among children, the number that the federal government was describing the administrative numbers as in Medicaid was far outstripping the number in the survey. We saw a smaller disconnect for adults, but it was still there. And then we probed a little bit around eligibility and found that some of the people that you would really hope would maintain coverage with this sort of policy, people who had had an income change or someone who had given birth and was no longer eligible by pregnancy, we do see that there are increases in their reported coverage in Medicaid, but still not as dramatic as you might think when you see those overall 90 plus million people covered according to the CMS statistics.
So, Ben, what are the implications of your study findings for policymakers and also for clinicians?
Well, I think the first implication really ties into this unwinding period that we're now in. When the governments at the state and the federal level have been trying to inform people that this redetermination process was going to occur, that everyone in Medicaid was going to have to go through an eligibility verification, the assumption was that most people understood that they had Medicaid and that what we needed to do was help them navigate this system of providing the appropriate documentation, making sure their contact information was updated. But our findings suggest that a lot of that enrollment growth during the pandemic wasn't well understood by the people in question, that many of them had been in Medicaid at some point, but then maybe in their minds moved on. They'd moved to other coverage, they had become uninsured. So a lot of the outreach may not have hit home because people we were conducting that outreach just didn't even think of themselves as in Medicaid anymore at all. So I think that's an important implication in that there are still several months left in the unwinding period, that states and community groups and the federal government that are working to educate people to help them navigate this process need to account for the fact that some people may not have really understood that continuous coverage policy in the first place. There's also a forward-looking component here, which is increasingly with the recognition that churning in and out of coverage in Medicaid or any other program can be disruptive for care. We've seen a move towards policies that promote continuous eligibility, not just related to the pandemic. So, for instance, Congress has now required, starting in 2024, that all states provide 12-month continuous eligibility to children in Medicaid, meaning that even if their families experience a change in income or a change in circumstance, they can't be removed from the program during that 12 months. Much like people who get their coverage through work, where typically you sign up once a year and you keep it for a year, that's the model now for children's coverage in Medicaid. But if we have families that don't understand that and think that the coverage went away because their income went up or because they got a new job, we're really missing an opportunity to promote continuity of coverage and continuity of care for the people that should be benefiting from this policy. And there's a related policy around continuous coverage in the postpartum period that has been adopted by over 45 states in the past 2 years. And this is another area where there's a great potential to produce positive changes for access to care and for health outcomes. We know we have a maternal health crisis in the US, and this is one of the tools that policymakers are looking to try to improve postpartum outcomes. But if someone doesn't realize that the coverage has continued for 12 months, despite the fact that they gave birth and now, traditionally would have lost Medicaid after a few months, we're missing the chance to really get the full benefit of that policy. So it has important implications for the unwinding, but really beyond that as we think about continuity of care in Medicaid going forward.
So, Ben, you served as Deputy Assistant Secretary for Health Policy in the U.S. Department of Health and Human Services from 2021 to 2023, and you had previously served as a senior advisor at HHS. You're able to speak so fluently about all of these policy issues, and I wondered how your research experience informs your role in federal health policy and how your policy experience might be informing your ongoing research.
Yeah, there really is a two-way relationship here, that the role I had in federal government at HHS in the Office of Planning and Evaluation, which we know as ASPE, is really an in-house think tank for the Secretary of Health and Human Services. And the work we do while in a government setting is very much rigorous academic quality work. And the expertise of the staff at ASPE is quite impressive, and the range of knowledge and experience is really a pleasure to be able to work with them. So when I came to that role, everything I had from my background as an academic researcher was relevant to conducting rigorous policy analysis to inform decision-making around issues including coverage during the pandemic, the expanded marketplace subsidies under the American Rescue Plan, the continuous coverage provision for Medicaid. And in turn, now that I'm back in the private sector and academia, the time I spend in government's just invaluable in terms of thinking about the issues that are really going to affect decision-making. What are the questions that policymakers have? What do they need to have good data on and timely data on to inform where they go forward? And one of the aspects of this paper that I thought was particularly important is the answer you get will very much depend on what data source you look at. And understanding that you could get quite different answers from two very reputable data sources, our best household survey on coverage and our official enrollment statistics in Medicaid, it's one of these cases where the temptation might be to say, oh, this is frustrating, these numbers don't line up. But here we actually have to dive into it and we have to unpack it because it has such implications for what people are understanding versus the way policies were designed to work, and also where we're spending money, right? Whether someone knew they had Medicaid or not, they were still getting bills paid to the managed care plans if that's how they were enrolled. We want to make sure that we got our money's worth, that they actually, as taxpayers, that folks were benefiting because we were paying for coverage to plans. We want to make sure people got care for it. So it really does inform the work I do as a researcher to think about the kinds of decisions that policymakers are making. And I guess a couple other things that have informed the way I approach my work now, having spent time in government. The first is you have to be able to speak plainly to people. You have to be able to take what is often fairly complicated methodological analysis or details of programs and make it understandable. And that's really important, not only within the policy world, communicating to policymakers who may not be experts on that particular issue, but also to the general public. And one of the undercurrents in my comments so far has been that policies only work if the people who are supposed to benefit from them understand them. And so it's really important that we not only study these things, but then can communicate them. And then I guess the last lesson I've drawn from my time in public service as it relates to research is to study what matters and to try to get ahead of the big decisions that are looming. What is a policymaker going to want to know 6 months, a year, or 2 years from now? And you don't always get it right. Sometimes you think you know where things are going and you're wrong. But if you can get out ahead of it, or as one of my colleagues in government used to say, if you can skate to where the puck is going to be, you're going to be much more impactful as a researcher, and that's critical for evidence that's going to actually inform policy.
Thanks, Ben. At the end of our podcast interviews, we like to ask a couple questions of our guest authors, and I'll pose the first one to you. What's the best advice you've been given about your career, particularly for developing policy-relevant work, such as your article in JAMA Health Forum?
For researchers who are interested in policy impact and potentially interested in public service as a component of their career, I would say get involved early. Don't wait too long. I think sometimes we have the expectation that this is something you should only do once you're really established and later on in your career, tenured or in senior faculty roles. And I think that misses just a critical opportunity to have the policy world shape the way you think about research and vice versa. So it doesn't have to be at a leadership role. I had a wonderful opportunity to serve as an advisor in 2011. I had just finished residency. I had done 1 year of my assistant professor faculty appointment, and my department chair was incredibly supportive for me to go down and get that experience in Washington to learn how evidence was being used in policymaking, how it wasn't being used. So that was really, I think, invaluable to shaping what I've done subsequently in terms of policy relevant research. And it was also definitely a contributing factor to the opportunity I had to return more recently in a leadership role. That experience is really valuable because government is a unique place to work and it's hard to replicate it anywhere outside of the government.
Well, from that vantage point, inside and outside academia, I expect you to have a great answer to our final question for our guest authors, which is, what do you think is the biggest change that we can expect over the next 5 years related to health policy in general or Medicaid policy specifically?
Let me focus on Medicaid. And I guess I'd have to say elections really matter because we could go a couple of different, quite divergent directions depending on what happens in November of 24. I think depending on who controls the White House and Congress, we could see an ongoing push towards more coverage expansion, efforts to try to induce the remaining states that haven't expanded Medicaid to do so, more support for policies like continuous eligibility, potentially seeing that for more populations than just children and in postpartum period. We might see greater effort to extend that period, for instance, in some populations, more focus on outreach, really trying to maximize the ability of people to enroll and stay enrolled in Medicaid to be as positive a force for quality and continuous care as possible. But alternatively, we know that the previous administration and the Republican Congress has been interested in other very different policies. For instance, tying coverage in Medicaid more closely to work and to seeing, revisiting of the popular idea in some states of using a work requirement as a prerequisite for being in Medicaid. Only one state, Arkansas, actually fully implemented work requirements in Medicaid previously, with disappointing results that essentially people lost coverage by not verifying their employment, but didn't actually induce increased levels of employment or community engagement. Georgia now has a very small scale version of this going on around their demonstration in Medicaid. But there are a lot of states that would like to do more of this, and the different administration would be potentially more amenable to this than the current one is. And there's also a lot of interest, I think, in fundamental reforms to Medicaid financing still among conservative policymakers, where rather than the current open-ended system where states have a match rate that is an open-ended commitment to fund eligible enrollees, to give states either a fixed sum per year or a fixed per person allotment that would shift more of the financial burden to the states and would create strong incentives to reduce the size of the program. That might have positive effects on the federal budget, but would potentially leave millions of people with less coverage or out of coverage. So I think there are really quite divergent paths for Medicaid, depending on what happens. And it's always true for any election, but especially in an election year where the control of both houses of Congress is very much up in the air. The race for the White House will be potentially very close. So there's a lot that we'll see, I think, about healthcare over the next 12 months, and the impacts on Medicaid will be substantial.
Thanks to our guest author, Dr. Ben Sommers at Harvard University. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.